We have time for Q&A, so we're going to shorten our break a little bit. I'm going to ask that committee members let me know if you have a question. We'll hand you a mic. And please keep your questions concise and without long comments so we can make sure we have time for all the questions. And I saw Lee's hand up first. So start there.
Thank you for this very impressive presentation of your process and of your analyses. I'm wondering when you expect to have information about the impact, not just on processes, but the impact on health and other outcomes.
We actually have that now. Yeah, we actually have really strong outcome data now. We were fortunate enough to secure a Centers for Disease Control, Racial and Ethnic Approaches to Community Health grant for 2 of the priority areas, healthy eating and active living and chronic disease management. So there were a couple of the outcomes were summarized up there, but there is good outcome data. A very fruitful and rich evaluation plan was developed under that funding strategy and funding that we received, and there are outcomes emerging already from that work. We're in the year 2 of that funding.
Are they
cycle.
population health outcomes?
Not necessarily population health outcomes. They're more tied to the intervention strategy. So, for example, the produce prescription, there are some outcome data looking at increases in fruit and vegetable consumption by we're able to determine how many of the vouchers are turned in at farmers markets and getting an understanding of how many of those are being used for how many patients they were prescribed to, and then a look at fruit and vegetable consumption.
2 quick questions. First of all, thank you very much. With your assessment, you had several different components to the assessment, and I was wondering if you could say a little bit about where the strengths, the assets that you assessed, where that came in the process, the sort of assets assessment. And then my second question is if you could say a little bit about how you got buy-in to examine structural racism as one of the key priority areas.
Sure. So from the community themes and strengths assessment perspective, that was done simultaneously to the community health status assessment. So in essence, we had a timeline to finish those assessments. When all of them were completed, we sat down with all the data. So we knew what had emerged out of the quality of life survey, what priorities emerged. We had the top 3 named for both the city and the county as a whole. And then we took that with the community health status assessment and actually looked at where they synergized and where they aligned. And then basically we went through a facilitated process to utilize that data in generating the priorities.
Yeah, as it relates to the eliminating structural racism buy-in piece, I would say that we have tacit buy-in because I think the initial driver was we had all this data that pointed to inequities, and people kept saying that we're spending a lot of money, a lot of time, energy, and effort, but we're really not seeing any pragmatic change in the data. So the issue became, so what do we need to do? That was the first transformation because people asked the question, what do we need to do? And then we pursued a course, the leadership, and the Place Matters, which is now called Collaboratives for Health Equity, interjected with a different view of the world and a different construct to consider. What I will say about this, though, is that it is not only iterative but evolutionary because people develop at different rates over different times. And I think the more deeply held are your convictions and your values about the way you see the world, it's very difficult to then hold multiple perspectives, which is necessary to talk about and to engage in equity work. So our idea is really to understand where people are on that spectrum, whether they're leading, supporting, or following, and then use that as the basis for trying to segment how to expand and speed up the transformation process. But you really have to kind of have a tacit buy-in by people kind of saying it's not working, and then offer an alternative that is plausible, at least in terms of data research and analysis.
And I would just add, we committed to choosing 3 priorities, 1 to 3, And when we went through the facilitated session with Common Health Actions, eliminating structural racism was the fourth.
Right.
And there was actually a vote and a discussion and a commitment at that time to select the fourth and make that our fourth priority. So it was that was a level of commitment and buy-in at that point.
It's very clear from your presentation that you've effectively engaged the governmental and foundation entities in your geography.
Yes.
Have you also engaged the for-profit sector and the healthcare delivery sector?
Yeah, we'll tag team that
Okay.
answer. I would say no, we have not. There are actually several sectors that we would admittedly say we do not have at the table. And I would say we have the least experience engaging private sector. So that is actually our next endeavor. We do not have private sector representation on our steering committee and in a very limited fashion in our consortium. But we're actually hosting on March 16th a private sector and philanthropy forum, really being able to describe how we can collectively invest in a culture of health locally. We want to look at where our priorities align, where our capacity and resources are aligned, and how can we really invest collectively moving forward. And that is our first opportunity to engage the private sector and to provide some context and some learning.
Yeah, and I would just add that we knew going in that one of the most difficult sectors to engage would be the private sector or in our corporate structure, just because of their focus and also because of the culture that has evolved in our community, which I do a lot of economic development and kind of financial services work with our Chamber of Commerce and our intermediaries that are in our ecosystem for our economic development organizations. And what I've learned through that process is that we must be able to articulate our value proposition in a way that comports with what their value propositions are and that we find commonality before we can move forward. We are still struggling to figure out what that language looks like in a way that's comportable and comfortable for everybody to begin with.
Okay, so we're going to have Robert, Allison, and then Hortensia that play all of the time.
This is Rob Duggar. Really always impressed by what's going on in Ohio through our work with the Gunn Foundation. We're active in early childhood, homelessness, foster care, and recidivism. I'm not an expert in public health, barely know how to apply Band-Aid, but
I'm with you.
what evidence has come through to me is that stress, cortisol levels are very important in many of the effects that you're looking at.
Yes.
And that these stress and cortisol levels and other factors are central to what's happening in the family. Parents, parent capacity. And what I'm struck by is you've not used the words family or parents anytime in the presentation, written or oral. And I'm wondering, where does family capacity or parent capacity and effectiveness fit, if at all, in your process?
Okay. Yeah. I think it fits, but I think what we would say is that the systems and structures that have been created are in a significant way producing the stress that families, parents, and individuals are experiencing in the places where they live. So that in fact we want to do anything about stress that's more than episodic or individually focused. We have to move back upstream to where the issue really is, or the issues are, and really work with those people to help them to first understand that the way you're operating is not benefiting everybody and is having deleterious effects on folks. Those are leading to not only shortened lifespans, but an additional increase in cost that we will never be able to sustain long term. But the other side of it is that I'm sure that it is not your primary intent to have institutions and systems that work that way. So, as I said when I was commenting, many times we think about how to impact the individual What we've decided to do is not to forestall that or to think about that as not being part of our construct, but we think about it in terms of how we impact systems and structures so that they can better alleviate stress and distress that families are having and individuals are having where they live.
Thank you very much for your presentation. I'm curious about the process of winnowing from the 14, if I understood it correctly, potential goals to the 4, and what might have tipped the scales away from, let's say, a pick 2, education or early childhood development. Is it that they were sort of distal to health, or can you explain sort of what factors tilted towards one group?
You know, it's interesting because we had more criteria than anybody could ever imagine for this process. We have academic institutions and government. We had all the criteria, but I think it was somewhat organic the day of through that facilitated discussion. I think to some extent you always have to deal with who is in the room that day as well and who's participating. But we presented all the criteria, we presented all the data, partners were fully engaged in that process. There were several convenings where we dove deeply into that, but when we had the facilitated session to really reduce from 14 to 4, it was somewhat organic. People had to gravitate towards the priority areas of choice. We broke up into groups and we started to craft narratives for each of those priorities. We looked at those through an equity lens, understanding who's benefiting, who's burdened. And so these issues trickled up organically from that process. In hindsight, we had folks ask, I can't believe infant mortality didn't make it to the top, or land use or one of those other priorities. And I would say those issues are actually still being addressed in our communities. A very fruitful movement around infant mortality, and it's actually allowing us to create some alignment around the eliminating structural racism work that we're moving forward in HIP Cuyahoga. But in essence, I think it was the grounding in equity and the framing and the opportunity for folks to really engage and understand what they're passionate about based on the data that resulted in those 4.
Thank you for the presentation. It's great to see how far, this work from your roots in Place Matters has come from the beginning. So my question was really about, following up on one of the first questions, it's very challenging to provide population-level outcomes and evidence of increased health equity. Can you talk about what are the challenges that you've experienced? One of them is, how far do you expect, is it reasonable to expect that you would have to continue this work before you see all of the health impacts that you're looking at? So I wanted to really hear more about, are you planning to look at population level health impacts in terms of being able to document increased health equity or decrease disparities, however you choose to put it? And if so, what have been some of the challenges, and how are you thinking of the time frame for that?
Sure. So for the priority areas, specifically the healthy eating, active living, chronic disease management, we're sort of on a 3-year timeline because we're, in essence, those two work plans are fully funded through the CDC's REACH funding. So the content of those work plans are being implemented. As I mentioned, the beauty of that was that we were provided consultative support and we were able to develop a very fruitful evaluation. So for those 2 subcommittees, we're actually working in 22 census tracts in the city of Cleveland and also East Cleveland. So we were very intentional about selecting those target areas. And so there are outcomes tied to the population in those 22 census tracts. For the other priority areas, for example, eliminating structural racism, our target initially is on our partnership. It's developing that readiness and that understanding of how we can continue to build capacity. And the clinical and public health is working at a systems level at this point. So while those will have population health implications, at this point, we're working on the opportunity to just bring public health, healthcare systems, and others vested in that work to bring those systems together around a shared assessment process and being able to identify priorities that are shared. So in essence, we completed our community health improvement plan in 2015. We have 5 years to, in essence, work on those priorities, and we're building in sustainability and the ability to measure outcomes in each of those areas. However, our focus is at this point also on the understanding that Greg described, is that it's oftentimes the partnership and what the partnership can leverage and influence in systems and structures that can be far more influential. And no, we have not mastered how to measure that yet. We're looking to the Collective Impact FSG Forum and really exploring the evidence. We know there's partners like the National Collaborative who are putting forth equity indicators, the Robert Wood Johnson Foundation's Culture of Health framework, and we've dove sort of head first in building that understanding. One of our challenges is resources tied to evaluation and measurement. Again, we have seen fruitful evaluation where we've had the resources from the REACH grant. At this point, we have limited to no resources for evaluation, and that's a focus for sustainability moving forward.
And I would just add one final caveat to everything that Martha says, is that as social scientists, sometimes we struggle with the idea of how you take individualized interventions, initiatives, programs, and then tie them to larger social indicators in terms of population health and those kind of things. I think that's what we struggle with. I think social scientists struggle with it all the time. I certainly struggle with it in the work that I do on a daily basis in the policy realm. And what I do know is that we have some very encouraging opportunities that Martha's talked about with the National Collaborative, with Robert Wood Johnson and others who are thinking about this in terms of developing indicators. Now we have to figure out what are the processes to get us to those indicators, and how do we then figure out how to make this giant leap and create a bridge between what we want to see over here and how we act over here.
Okay, Helene, last very quick question with very quick response. Yeah.
Okay. Thanks, and just to add my comments to say that this is incredible work and really wonderful and fascinating, and I think all of us probably have 10 or 15 questions we'd like to ask, but we won't. I guess maybe it's a little bit tied to the issue of bringing in private sector partners, and clearly, you know, none of this happened in five years, and so a 5-year grant is not going to address it. And I really think about, you know, what is it going to take to sustain an effort like this? And I do think bringing in other partners, including the private sector. So I guess my question is more, you know, we always talk about the economics and the economic impact of poor health, but it's not, those economic factors are not necessarily felt by the same people who have economic interest. And I'm wondering how you could better tie what the economic issues are around poor health in the county to really make that more tangible for people who should have an economic interest. And so, you know, do you have economists looking at this, and are you really helping to make the case so that private sector and others will see why it's in their economic interest to actually get involved with this and help to sustain it? And so I think linking what those economic incentives are for the county more broadly might be a way of helping with the sustainability.
Yeah, I think you're absolutely right. That's what I was alluding to when I was saying we haven't created a common language yet and a common understanding for the participation of the private sector to join us or us to join together. So I think you're absolutely right. Yes, we are doing all those things, but we're also thinking about who we can go to as champions in the private sector, who we can encourage to join us, understand us, to help us translate that information better for the population that they represent. So that's just another thing that we're thinking about.
Okay, so we're running late, so I'm going to ask for everyone's help. We're going to take a 5-minute break. We're going to reconvene at like 10:37, because everyone has such a great wealth of knowledge to offer today, so I don't want to cut anyone's presentation short. The restrooms, down the steps, make a left, and then another left before you enter the Great Hall. Same thing, all day the cafeteria will be open. You make that same left, and there's stairs going downstairs. Cafeteria is a level down. See you all back in 5 minutes.